Just share your screen. Is it shared? Okay. Your camera is on, but let me know when you are ready. Maybe a presentation mode. There we go. Are you ready?
We're ready. Hello, everyone. Can you hear me? We hope you have some energy saved up for us today. We are the Data Pandas, and our solution is transforming healthcare access and efficiency in South Africa. This is our team. I'm not going to go through everyone, but we have Smangang, Gosnati, and Bongani Baloyi. I'm just not going to point out to them. This is what we're going to cover today: the background, the data process, data modeling, our findings and results, and the conclusion, and lastly, we're going to do the demo. Firstly, before we get into a lot of things, I have a story for you. And I think this is a story that some of us may be familiar with. Over here, I have Miriam. Miriam Grootboom is 56 years old, and she was diagnosed with diabetes like a few years ago. However, she does not have any medical aid. She's from a rural village, and often she has to walk very long hours to the clinic. And because we all know our facilities, our public facilities are not that great, this means that when she gets there, she still has to wait for extra hours before she's attended to. However, sometimes she is turned away because of lack of resources. So once she was turned away because of the facility did not have insulin. The problem: South Africa has over 55% of the population is living below the poverty line. What does this mean? This means that we are facing a financial burden. A lot of South Africans do not afford financial or medical aid. What this means is that a lot of people are demanding on public health care, which increases the reliance on public health. And what this does is it overburdens the facilities and the resources that our public facilities have. The impact of this is that, like Miriam, a lot of struggling South Africans will be turned away, and this further deteriorates the health of a person who is already ill. I'm gonna move on to Smanga, who will explain the data process and the data sources.
Sanmanan, I'm going to talk about the data sources, the data process, and data modeling. We are working on our problem, the challenges in South Africa facing our community. We use the sources, medical aid, record data, treatment data from the Eltron, and then the poverty line from State SA, and then electronic medical from Kerry. We ran the data process, cleaning the data, feature engineering, data collection. We cleaned the data post. When you got the data from Eltron, it was a lot of data, and then you need to check the missing weight, missing columns, and also we need to check the duplication of the data to avoid outliers, to avoid any misinterpretation of the data. And then we ran through to check the data analysis or data exploratory. And then we ran through the monthly trend in claims of data. Just ran the whole data pipeline from 2023 to 2024. We see that there's a bit of outliers at the end of 2024, which one may say it because when they ended the data collection, it was a mid-year in 2024. And then going to the data modeling, there's a saying that all data are bad, but some are useful. So we went to data modeling. We compared the data, different data to check which one will fit for our problem and then understanding the challenges in South Africa. We went through gradient boosting, regression, which works on complex relationships, hyperparameters and loss function. We went through linear regression, which more handles the linear relationship, works well with the low dimensionality and short prediction. And then finally, we went through random forest regressor, which handles nonlinear relationships, works well with high dimensionality.
10 minutes.
In this one, we realized that random fits well with our program or our research. And then we went through the geospatial modeling, optimizing the resource allocation and natural, and then also went on the model natural language processing. We ran a data analysis on actual and predictable claims over time, which shows the nonlinear relationship, and then we also check the monthly and see if there's any correlation between a long term and a short term. And then now I'll hand over to my partner, Kosnat. Thank you.
Hello. Hope everyone is well. So, our findings from the data was that we identified accessibility gaps. People are always too far from where they can get help. Through our data, we also found out that in medical aid claims, places like Limpopo, mostly rural villages, they're probably one claim, 2 claims. And then we saw that, okay, that means everyone there is relying on public health. And then we also identified that resources were not spread out well, because now if you see that there's a lot of claims in Gauteng and there's 0 claims in KZN, that means that there's probably nothing there. So what we want to achieve through this is to create a predictive model that's gonna give us demand, how the resources are gonna be demanded in each place, and then reduce overcrowding at facilities by reducing unnecessary visits, have an AI symptom checker which empowers people to seek early intervention. So what that AI checker does is that you just go on your phone and then you put in your symptoms, and then if maybe it's something serious, it's gonna maybe recommend where you have to go. So for our solution, we created a digital app which is going to address accessibility, efficiency, and transparency. So the app is going to have a card on it, because most of the time clinics give people those paper cards which always go missing. So with the digital card, everything can be safe, and maybe you just have a number. Maybe sometimes you don't have it, you just call out that number and they know who you are. And then another thing it's going to have a facility locator, so that if maybe you have cancer or have maybe anything like that, the app can optimize to okay, which place is best for you to go. Or maybe if it's too far for you to go, they can bring things in zip line, which maybe can just deliver the medicine where you are. And then it's going to have integrated health records, so doctors can see what's happening, and also you on your end can see what's happening with your records. You can check maybe for the next visit, which also just leads to telemedicine, where You can maybe talk to your doctor through WhatsApp or through maybe face chat, things like that. And so the social impact of this is going to be improved health accessibility, enhanced system efficiency, reduce socio-economic inequalities, and give us economic benefits because, you know, if there's a healthy country, there's a healthy economy. I'm going to pass over to Balisa again.
5 minutes.
All right. We can see that XCare is meant to be a transformative app that is meant to bring back the dignity and hope to our people by addressing challenges in the South African public healthcare service through the use of technology, by bridging the gaps towards things like accessibility and efficiency. The limitations that we faced were data access, because of the data we had to maintain a lot of its privacy. And another limitation to the project being implemented is that in order for it to be implemented well, it needs collaboration. So it relies on collaboration with other facilities such as government and healthcare facilities. Because this app includes people's personal information, health information, we need to ensure that it is highly private, and we do that by installing hashing. So that is an end-to-end encryption, which ensures that the user's details are kept private. Another tool that we're gonna utilize is session. That means that if I leave my laptop open, after a period of time, it's gonna switch, the app is gonna switch off. That means the person's personal information is gonna be protected. Also, it's gonna be available on role-based, and before anything is gonna be put in there, we're gonna take the patient's consent. For future work, we'll be conducting pilot programs in different groups or different regions to test the app's effectiveness and gather user feedback. We're gonna move on to the demo.
So I'll just start with maybe like what the government is gonna see in their dashboard so that they can allocate resources appropriately.
It's about 2 minutes.
Okay. So this, they're gonna see cities with lowest
Sorry, we can't see your screen.
Oh,
I'll pause your time.
okay, wait. So it's gonna have CT analysis. So places with low claim incomes will be investigated to get why there's like very low claim incomes. And then resources will be allocated there. And then places with like high utilization rates, they'll send out maybe more doctors there, send out more resources so that everyone that comes there can be assisted. And then maybe we're also gonna give you a preview of like the user, how the user app is gonna be. Bongani. Let me just look for that slide for you.
Good afternoon, everyone.
you there?
Yes. Okay. 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 Our app, I'll go through the way our website will be. We'll be using a website to make our solution to work to our community. Our website will be having a landing page, a registration page, and login page, and user a profile page, and doctor profile page, and then and where you can see a search functionality, facility information, appointment booking, and where you can see your user health profile, medical history, current medications, and lab result, especially when you did a blood test, you're able to get result via this app. And then telemedicine is where you can see appointment scheduling, a consultation interface, doctor information, and health data sharing, and other things. And before you use our app, you'll have to go through our privacy policy so that you can agree on how our website will be, you will agree to use our website. Because our website will be having your health information. If you have HIV, our app you'll able to see your HIV result via app, as Palsa was explaining about it. So,
Your time is up. I'll give you 1 minute to wrap up.
okay, thank you. As we move forward, we'll ensure that we'll ensure that we meet the policymakers and stakeholders and community leaders so that they can, we'll ask them to join us to make this solution to work efficiency, effective, to save our community. Thank you.
Thank you. Well done, Team ALX. Now it's the time for questions for our judges. Any questions? Judges online, I see, who's the first one? I'll start with Geoffrey and then Khotso. Geoffrey, over to you.
Thanks, Chair. I looked at their title, Transforming Healthcare Access and Efficiency in SA, but their presentation screams of access only. Maybe they can, in confidence, help us to understand how did they deal or they measure efficiency within their solution. Because even if in data collection, there's accessibility gaps, they track devices, we can see even in the screen in front. But I'm battling with the efficiency part.
Thank you, Doc. How are we gonna measure our efficiency that when, let's see, when someone wants to go to Soweto, generally in South Africa, if we want to reach in Soweto, there's no access, hospital access in Soweto. So you need an efficient way to find, okay, which place I can reach faster and then get medicine faster. Our app then will locate your facility that is much more closer to you or much more easy and short line that you can get your medicine. So we use a facility locator and then the availability of a doctor around you and then also booking your doctor. Thank you.
Thank you. Khotso?
Yes, thank you. Thanks for the presentation, guys. That was good. My one question is, I see that there's a lot of features here proposed in your solution. If we could say that we must take away, okay, so what features do you think are critical to the solution? Like what is the core of this mobile and web app?
We are building a system of access to healthcare in South Africa. So this is a holistic system where, because it doesn't matter if you get a great doctor, but I can afford it. So we put a system where someone can integrate the NSA and the private sector, and then they leverage an easy access where NSA can pay for ordinary patient. Because remember, poverty line in South Africa is 1,000 per month, and then an average payment in medical aid is 3.5. So someone who is earning 1,000 a month can't afford medical aid, quality healthcare. So we're leveraging that efficient and then an easy way to get a quality healthcare system.
Thank you. I've got one more question on the floor from our judges, and then I'll go online on chat.
Good afternoon. I'd like to point out that your system looks quite good. It's quite impressive. I just wanted to know in terms of population dynamics, did you actually, because I saw that you said that in Limpopo there's fewer requests than say in Gauteng, but if you look at the population in Limpopo, it's lower than in Gauteng by far. Did you factor those population dynamics into your system, basically when you did your assessment? Thanks.
Okay, so we use the Altron data, and then, so even if we say that there's like a low number of people in Limpopo, you cannot have like one claim for a whole month and think that's okay.
Okay. I'll take questions online now.
Does your solution integrate with existing healthcare systems in South Africa? If so, how? And are you using APIs or other frameworks to connect your solution to healthcare providers and patients?
Not yet, because now government are busy with national health insurance. They're still in phase 1 and they will finalize it by 2028 and they will continue to phase 2. So our solution is not yet existing into our community. We are trying to accelerate I cannot say the same solution, but because us will develop the unique features, not the same as they are busy building, even though we don't know it.
Okay, one more last question. If you look at the data, the Altron data, according to your understanding, is that a population or sample?
I think it's a sample.
Okay. So what's the difference between a sample and population?
Sample is example.
No, it's not an example, but we do have a sample and a population. I'm sure you've been hearing the word population, and there's a sample, okay?
So a sample would be like, so if the whole population is 5, and then you just wanna maybe pick out one out of that whole 5. So that one would be your sample space out of the
correct.
5.
Thank you.
Thank you.
Okay, I'll make exception. One last question from the judge on the floor, and then I'm closing the questions now for ALX.
Okay, thank you. Yeah, just for clarity, I think you demonstrated a web app there and then you went on to a design page. A difference, are they 2 different applications or it's one application just with additional features, the one that you had on the design? And from what you have implemented already, what lessons have you learned? What effort will it, if it is the same application, what have you learned and what effort will it take for you to have those additional features if it is one system?
Okay, so it's one system, but it's separated into like, there's gonna be 3 users. There's gonna be the government, and there's gonna be like the healthcare people, and then there's gonna be the users. So the one with the graphs was the government side. So once the NHA is like established and there's like access for everyone, the government can like maybe then like send out their resources like in an efficient way and like in an optimized way. Because now they're just gonna have a dashboard and they're just gonna look at the numbers from there and see where things are needed and where there's maybe a lack of things.
Okay. Thank you so much. A round of applause for ALX. I think this